From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing the article, Contemporary Outcomes of Cholecystectomy in the United States. We are here with two of the authors, Dr. Cody Mullens and Dr. Telem from the University of Michigan. Well, thank you for joining us today to discuss one of the most common operations performed in the U.S., cholecystectomy.
Yeah, thank you so much for having us. There's never a dull moment in discussing cholecystectomy, and we're always very excited to come and share some of our work.
I'd also really like to congratulate you as the authors, because even though cholecystectomy is one of the most common operations performed, we really were missing these type of data on trends over the past 10, 15 years. So to start, can you tell us a little bit about why you embarked on this research and share with us your methodologies? How did you go about it?
Yeah, so at a high level, effectively, the reason that we wanted to do this study is we've seen a lot of high quality data coming from Europe on this very topic, but also recognize that we have strength in both data collection methods here as well. So we decided that we wanted to evaluate uniquely in the United States contemporary outcomes following cholecystectomy, recognizing that the outcomes data, patient populations all may be a little bit different between existing data and the patients who we take care of here in the US. And so we leverage Medicare claims data, specifically inpatient claims, in an older patient population who were undergoing cholecystectomy and wanted to better understand over time areas where we may have improved as surgeons from a quality standpoint of this common operation, and also potentially identify areas where we may not be improving or getting worse to hopefully steer future quality efforts.
And I think it's kind of a bifold story, one of passion for quality improvement at scale for a lot of the population who oftentimes can go underrepresented or underlooked at by traditional studies, which may focus on non-common conditions, understanding how the attention we've put in past years around safety and cholecystectomy, prevention of bile duct injury may be important, how changing practice patterns may have impacted that, and a story of mentorship. Dr. Mullens is very humble. He's one of our residents here at University of Michigan with a passion around policy, particularly for persons in underserved and underrepresented areas who are most at risk when they come with different conditions. And we really wanted to understand not just across the population in the US, but even across pockets of the population. Where are we doing well? Where is there still opportunity to improve? And where should we spend the next decade focusing our efforts, knowing that you can't boil the ocean with various quality improvement metrics?
And to recap a little bit for our listeners who may not have had a chance yet, you guys performed a retrospective cohort study from 2011 to 2021, so an entire decade of data. And you evaluated over 516,372 Medicare admissions. This is a ton of data, obviously, to sort through. But let's jump in and start talking about what did you guys find? What were your main results? And in fact, did any of those results surprise you?
I think the time period is really interesting because when you think about the time period, there's more going on than just technologic improvement. There's also conversion from the inpatient to outpatient, fluctuations in where we care for patients and how we care for patients. And essentially, when you're looking at an inpatient Medicare patient population in this time period, you're looking at everybody who had a cholecystectomy, who was a Medicare participant, to probably the sickest of the sick that needed their gallbladders done as an inpatient versus an outpatient. So to tell you that we were surprised, if not shocked, to see outcomes improvement in this population and to see decreases in hemorrhage and various rates of infection was actually quite surprising to us, because we had anticipated actually seeing the opposite, knowing that we had a skewed population.
I think the other two surprising findings, just to dovetail off of what Dr. Telem said, was specifically bile duct injury has been getting discussed a lot lately. And we were pleasantly surprised to see that bile duct injuries substantially decreased during the study. And another area, kind of on the other side of the coin of areas that we were surprised, was specifically identifying that growing proportions of patients were undergoing percutaneous drainage procedures postoperatively, suggesting that patients either are developing accumulating fluid collections at higher rates that need to be drained, or that we as surgeons just have a lower bar or are diagnosing more of these postoperatively. And so I think those were the two big surprising findings from my standpoint with the study.
It really stood out to me because what I loved actually is that you did show that over the course of this time period, over this decade, patients became more complex. In fact, there were increases in the comorbidity burden of these patients. And yet you saw significant decreases in length of stay, 30-day readmissions, complications, serious complications, 30-day mortality, and in-hospital mortality. So our patients are sicker, but they're doing better. Do you have any thoughts on that?
So I have a hypothesis that we can't substantiate with data, but I guess that's what podcasts are for, getting to hear some of your thought.
Absolutely.
I think it's changing trends. I think it's attention, not just to the critical view of safety, but what is safe during a cholecystectomy? When should you stop? And honestly, this move towards partial or subtotal cholecystectomy, which I think the increased drainage is probably a proxy or surrogate marker for, which begs the question, as we're doing more and more subtotals, which we know anecdotally we're doing, almost impossible to capture in claims data, no matter how hard we've tried, the question becomes, what's the trade-off? Are we preventing bile duct injuries at the expense of some more percutaneous cholecystectomies? Well, that seems great. I think the bigger long-term trend, which everybody talking about, is what are the rate of re-excision of cholecystectomies and are we doing partials correctly? But in my heart of hearts, without having any evidence to prove this, I think what we're picking up is this transition to fenestrated or partial cholecystectomy as a move instead of just persisting for the sake of persisting, or alternatively just converting to open, which we know from previous data actually increases the risk of bile duct injury and is a surrogate marker for that.
I agree. I'll say in my own practice again, this is what podcasts are for. It's true. And that obviously, previously, that was the thought. If you couldn't do it laparoscopically, the safe thing was to perform an open cholecystectomy, but the data showed us otherwise. And so for, again, our listeners who may not have had a chance to read the paper yet, we're talking about this post-operative percutaneous drainage. In fact, the rate of that doubled from 2011 to 2021. And post-operative ERCP also increased by about 40%. Now, we've talked a little bit about the post-operative percutaneous drainage, maybe as a proxy for subtotal cholecystectomy. Do you have any thoughts about post-operative ERCP?
I think a couple of things. Potentially one is that people are utilizing IOC, identifying stones in the operating room that may very well have passed on their own. As we know, based on existing data, that the vast majority of stones in the CVD are going to pass on their own without needing any form of intervention. And for the surgeons who are frequently using intraoperative cholangiogram as an adjunct to better delineate anatomy, that may be contributing to it. Additionally, surgeons may have evolving thresholds for consulting GI postoperatively. If there's a bump in patients' postoperative labs, that may be skewing our data as well. I don't think we have really great opportunities in this type of data, large retrospective administrative claims data, to truly delineate that. But I think those are kind of a couple of things that may be contributing to it.
And I think the next generation of where we need to think about quality improvement really rests on that question of when do we need to get an ERCP? I know when you talk to our hepatobiliary surgeons, their mantra is all bile stops eventually. And I think that there probably is some truth in that. I think if you're doing partial or fenestrated cholecystectomies, bile is an expected outcome in the drain. And without a distant obstruction, and as long as you know that, what is our threshold? Should we be having sort of a knee-jerk day one reaction? Should we be just managing through after a couple weeks and saying, hey, the most likely outcome is this is going to stop on its own, so there's no need. And I think we need more guidance and standardization around thinking about how we utilize and how we apply ERCP in the postoperative setting, because while it's a phenomenal modality, it's not without its risk, right? And we all know persons who've had the ERCP pancreatitis and they get really sick. And it all starts with, well, we think we see a stone there. We think there's a small bile leak. And to me, that's sort of where our eyes are turned. And for there, like Dr. Mullens said, it's a little bit hard to pick that out of claims data, but seeing signal like that really kind of wants you to push into system level data, registry data, anywhere where you can start getting a little bit more granular data on the who, what, where, when, and how we should deploy that resource.
And I think one of the other interesting things for me is that the rate of bile duct injury did decrease from 0.19% to 0.12%, and that reached absolute statistical significance. And it's interesting because from a technical perspective, the only real change we've seen is the addition or increase in use of robotic surgery. But you also mentioned earlier, Dr. Telem, about quality improvement and initiatives. What do you think has led to this improvement in our outcomes?
I think we have, one, better instruments, better agents, better hemostatic abilities now than we did 10, even 15 years ago, whether it's powders or argon or the million different things at our fingertips. I also think there's been tremendous educational push through SAGES, not to plug them right now, I'm clearly biased, in the college in terms of thinking about bile duct injury prevention, working together with AAST, a lot of the EGS societies, and talking about what is a safe cholecystectomy, why is it important, really pushing that education. And then three, the evolving modalities of, again, the acceptance of partial cholecystectomy rather than sort of knee-jerk conversion to open, to me are probably the three biggest factors that explain those differences and lead to new quality improvement questions, which is really, like you just mentioned, which is how do we make sure everybody's actually doing an appropriate subtotal cholecystectomy and not, just kind of a domectomy or some of the other things that we see so that we don't run into problems downstream of, repeat cholecystectomy. How do we think about what bile leaks do we ERCP, right? And which ones do we leave? And when do we set those metrics to make sure we're not over-treating people? And so I think it's an exciting time to switch some of that quality improvement focus based on this initial signal.
Those were a lot of exciting, great next steps. And really, what should surgeons who are listening to this podcast who have cholecystectomies already on their schedule for later this week, what do you want the big take-home message to be from your paper?
I think we should all feel really reassured that this extremely common operation that we're doing, we're continuing to get better at, although it is a very frequently performed operation. We can take really excellent care of these very sick patients, right? Because these are Medicare inpatient cholecystectomies that are happening. And also go into the operation. I learned this from when I was a very junior medical student. It's never just a gallbladder, right? Despite the improvement that we see in this study, there is legitimate morbidity and mortality that can happen from this operation when it's not performed thoughtfully and safely.
To me, it's kind of like twofold. I think while we do show improvement, I don't think we're at the end of the road with needing quality improvement. And I think it just opens up a new or next set of questions that we need to look at as we continue to evolve. It's never just a gallbladder. And I think it's really important that we continue to stay focused on the common surgical conditions that impact our patients every day and don't lose focus on continuous quality improvement for them, as well as for the really large cases, the complex abdominal cases, which are important and don't touch as many people. So I think it's really important we just stay focused on continuing to help the masses, to continuing to push the needle. And even though we're improving, the job's not done.
I love that. Thank you so much. Dr. Mullens and Dr. Telem, thank you so much for joining me today to discuss your article, Contemporary Outcomes of Cholecystectomy in the United States. Our listeners can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening. Have a great day, y'all.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.